Any questions from the floor? If not, so start with you, Shep, just to look at the posterior malleolus. If it's just a small fragment and it's not associated with shear and with a syndesmotic injury, you can probably fix it anyway. But if you got a real fragment that's associated with shear, the syndesmosis is gone. So what's your favorite way of fixing it? You go posterior medial or posterior lateral? Which way do you do?
Posterior lateral.
Yeah.
Yeah, I like posterior lateral as a workhorse approach because you're almost always dealing with a problem either of the fibula or the posterior tib fib ligament and the stability of that fragment. So I go posterior lateral.
I ask that because I do a lot of them posterior medial, because I'm lazy. I hate to kind of turn the patient over again, so I don't like to get them put up on the side. I do a figure 4 position, go through a posterior medial approach. I get my posterior mal through that one, and then you can do your medial malleolus through that, and then do the anterior approach. And if you don't make quite as curved an incision as we saw through the anterior medial, you can do a straight line incision down to the foot. You can actually do both those incisions together. So this goes through. So for the P-law, just to look at, we just had those things there. So again, one of the things that comes up, and I see all the time, is that you get your anteromedial plate in, and you still have that little fragment attached to the fibula that you tried to get in. It's really kind of an angle shot that you can't get from the anteromedial approach. It's kind of so sometimes I'll make a small, not a big incision, but a small incision just to perk that screw. Do you use that technique at all?
Yeah, I mean, I think one of the advantages of, like, I don't know if you saw, I cheated the incision like a centimeter lateral to the crest, so it's quite lateral. So actually with that, I usually can get over with like a sharp home, and I can really crank it over and get the screw in. But yeah, I think if you're not able to for whatever reason, then yeah, really limited, perk incisions, totally.
Yeah, so these wounds, and I agree totally with what was said, as far as 2 to 1, but you can make small incisions, that just get your screw through the hole, either it's on the lateral side or the medial side. You can make a really small incision to see the plate, see the hole, and get your screw in an accurate direction from one side or the other. So I think it's good. And what about the os calcis now for you, Jim? You got everything fixed. What's your post-op going to be for that patient?
So we do a little bit of a orthotech test. I give them the open book answer before they leave the hospital. Is that we put them in I put them in a bulky cotton splint, and then we look at the ACE wrap. So if they're when they come back in at 2 weeks, 2.5 weeks post-op, if that ACE wrap is thrashed and dirty and everything else, they get a cast and we forget about them for a while. But if not, then I put them in a cam boot, allow them to start doing a little bit of motion with it. I find that the swelling goes down faster if we can move them. At this conference a couple years ago, we really talked about the value of early motion in these injuries, all of these injuries. But you have to trust the patient, so that dirt on the cast or dirt on the splint test for me is kind of a watershed of whether I am going to trust them to keep the splint on, keep a boot on, and then let them start moving early on.
Right. So everyone agrees the Saunders 2 and Saunders 3 you get as good an open reduction internal fixation as you can, but the Saunders 4 that are completely smashed, there's some literature that would support either open reduction plus a subtalar fusion, or open reduction then a delayed subtalar fusion. So what do you follow?
Yeah, I think that he has also gone on and showed more follow-up of that almost all of the 4s, and it's actually a surprising number of 3s end up needing to be fused. I think the time down for work warrants a primary fusion, but you can't just fuse it. You need to, like you said, you need to restore the height, restore the anatomy, because this is the foundation for the ankle. And so if you leave it flat, leave that bowler's angle flat or inverted, and then fuse them in that position, they're never going to be happy. So I'll take the time. I'll do an extensile lateral, like I said in my talk, and fix it, stabilize it. But then I will also then add two screws through the tuberosity and really denude the bone surfaces of the talus so that we can get a fusion. There still is a surprisingly low rate of fusion. There's a fair number of non-unions. They're higher if you do it as a delayed fashion. You have the
Right,
hematoma,
right.
so you can get a higher fusion rate.
So you have to do all the fixation, as Jim's saying, and get it perfect, and then you decide. When you're doing that, you denude the articular surface and then pass screws up. That's the one time when I use fully threaded screws as opposed to compression, because you want to hold your os calcis out to length at the same time you want to cross the subtalar joint. So you want to add some compression, but not a lot. So again, the Saunders 4 is a different injury. So when you do any other things you want to add for that at all? No, good. So Dave, the videos that you did were good. I do something a little bit different than that. But so where do you fall in the posterior medial approach now? You didn't suggest that in yours, and I find that a fairly good utilitarian workhorse for getting the posterior medial and the medial side on without having to rotate the patient around. What's your thoughts on that?
Yeah, I mean, I showed it in the first talk, and I just didn't have I don't have a video of it.
I caught you on that, see?
Yeah, but no, I mean, that second case, I use it. I think, like I said, for me, we're doing the more extensile anteromedial. That kind of makes it a little bit difficult to do the posterior medial. So with that one, I'm trying to kind of get it all through one approach. But when I do an anterolateral, I think that almost always needs to do something for the medial side. So it usually is sort of, it's not like I divide it into a couple different, one is like a very extensile posterior medial where you're, it's a really long incision and you're actually working on both sides of the bundle. That I do very rarely, but the more limited posterior medial, just kind of where you just sweep a little bit under the posterior tib tendon enough to get back to that fracture line and get it reduced. That I think is, very useful, particularly with an anterolateral.
Yeah, I may not be as accurate as you with my plate placement because you want to put it on the apex, but I use a T-plate back there because I find, if I don't get it quite bang on, the T-plate covers the whole posterior surface. Do you use the T-plate posteriorly or do you use a semi-tubular like you were using?
Almost always semi-tubular. I just think there's a lot of twist on the back of the tibia, and so with the T-plates, it's hard. You really have to get it twisted just right.
Oh,
or else
yeah.
The edge of
You gotta be
edge of
accurate.
that T really lifts up under the FHL, and I just find it like a lot of more fuss to do the T-plate than to just do the third tubular, and usually it's adequate fixation. And I'm talking more like posterior malleolar fractures. If it's a pilon and you're doing the Volkmann and you're doing then I use a stouter posterior plate because often you're doing, especially if you're doing two positions, you're going to be doing unicortical screws, and it needs to really hold on to things while you make your flip and then do the front of the fracture. So then I tend to use a little bit larger
What do you
plate.
use? Use a T-plate or?
Yeah. So I use a 1/3 tubular and just, 3-hole plate, or depending on how high that fragment comes up for specific for posterior mal. I think just a couple points with it is don't contour it. Leave it and spring it in. Let it pull down. It's truly a buttress for that. The other part is that I think one area where people will, disrupt the PITFL, the posterior part of the syndesmosis, in the approach, and you showed it in your video to really preserve that. That's the whole reason you're there, is so that you don't have to fix the syndesmosis. You're actually giving an anatomic repair. Do that plate before you do any other fixation, because you can't see that you've got articular surface congruity if you've done the fibula first.
Ross?
Yeah.
Yeah. A couple of things I've learned over the years the hard way. When doing complex ankle fractures, I always put a bolster under the calf. I don't like the heel resting in a supine patient on the table, because you start rotating and the heel stays put, and then you've got the ankle working. Again, the mortise is not going where you want it to because the foot's not moving. So I elevate, and I find it makes it easier to do multiple approaches that way because I can rotate the leg much more easily. And the other thing is to have everything in the room that you need. I personally learned to do ankle fractures without a tourniquet. But I always found that oftentimes I had to put it on later, so I'd have a sterile tourniquet available if I needed it later. And when you work without the tourniquet, then you're not so conscious and feeling like, oh my God, 2 hours is approaching and I gotta let it down and let it bleed. If you get comfortable with doing malleolar fractures and plafond fractures it's surprising how little bleeding there usually is.
Yeah, I agree. Peel off. A tourniquet, I don't worry for the ankle, not too much, but I think I put it on and you elevate if you need it, so that way it's available. Any questions from the floor at all? Yeah?
Talks, guys. With the Divergent Lisfranc, we saw some nice plates in the session. Some people use a tightrope, but my experience is that if you put a screw through there and you remove it later, there's always a little bit of widening. It's almost like concerns you have about the syndesmosis in the ankle. Just wondering if you have any tips, whether you think a tightrope is a good way to go and leave that in, or whether any tips intraoperatively to make sure you have that keystone perfectly reduced so it doesn't widen when you take the screw out later.
Yeah, I haven't used tight ropes personally. I try and get it, as I say, anatomic and make sure it's fixed. And I think if you're getting some motion, it usually means you're bringing your screws out a bit early. So you should leave it in. If you're worried about it, I'd leave an extra few weeks in before you take it out. So I think 6 would be the minimum. 8 or 9 weeks is fine. And so I wouldn't take that until I was really satisfied that your ligaments healed. It usually means you're getting some stretch there. But any other tricks? I may use a tightrope.
Yeah, no, I don't use the tightrope there. I use it for syndesmosis and a lot, but for the same reason I don't use it in the foot is that's a three-dimensional instability. It does nothing to control A to P or plantar flexion, dorsiflexion. And so I worry that tightening up your intermetatarsal angle with a tightrope isn't really reducing the deformity. I think what it's doing is temporizing it, but then there's this gross motion, plantar flexion, dorsiflexion, that precludes it getting stable. The pseudo fusion that you were talking about yesterday. Does that make sense? I think I think a screw fixation will get you a better stabilizing. I take it out, but we're going to wait till the Canadians teach us about what.
I take
Yeah, I
it,
was gonna say,
but we're
I
taking
meant-
out late at 6 months. So I think the big thing, if you're getting some stretch and you're getting some displacement, I think you're bringing your screws out a bit too early. So I just wait a bit longer and then get going. You can get them mobilized with the screw in, but you can just take it out a bit later. That'd be my advice to you. Yeah.
Another philosophy, which is mine, and again, I'm a little bit biased towards more treating a high-energy Lisfranc practice, but I just leave the hardware in. I'm like in that camp.
Oh yeah, no, that's fine.
So the other option is just don't take it out.
But if you have a screw between the first and second metatarsal, that's what you're talking about, right?
Yeah.
Yeah.
You have a screw between the first and second.
Yeah, I don't do
metatarsal.
that. I don't do that screw
Yeah.
usually, except for in like a Lapidus type situation.
Yeah.
That's a classic Lapidus sort of screw trajectory. I worry that because then I end up with, because I usually have a couple screws in the first, and then
Right.
that screw, it's like so much stress riser in the first, so I don't really like that one. You can break the first metatarsal. So I do the one that goes from medial cuneiform to base of second. That one I'm comfortable leaving in and not worrying about. But I would worry about that one that goes between 1 and 2. So
Yeah, I would agree totally. It's an unusual screw to use, so you should be able to get the reduction at the top. Yeah, that's where you should get it. Yeah.
So I think we're probably all in agreement. When I thought that I put it metatarsal to metatarsal, I think you stabilize. So I stabilize the first metatarsal to the medial cuneiform, stabilize the second ray to the cuneiform, and then I put a screw from medial cuneiform into the second metatarsal.
Right.
That's the fixation that I do. I don't. I know the technique. Bob Anderson doesn't do it either now, but he invented the concept of putting the tightrope between the two. But I don't think that is the same. You can't do that with a screw either.
Okay.
Thank you.
Any other questions? If not, on to the next session. So who's